want to welcome you to our amazing Lung Cancer and Communities of Color webinar. Lung cancer disproportionately affects communities of color. And today we're going to discuss what lung cancer screening is and who's eligible to be screened. We're going to also talk about early detection and early intervention, what that looks like, and why it's so important. Understanding surgery, chemotherapy clinical trials, and our goal is to really empower you to be a partner in your care with your clinical team and to understand questions, be empowered to ask questions, and to get involved in clinical research. We have an amazing lineup of speakers for you today. Some of my colleagues here at Memorial Sloan Kettering Cancer Center. But first, I'm going to be handing it over to my incredible colleague, Ms. Leticia Mercado, who is the Associate Director of the Office of Health Equity. Since joining the Office of Health Equity at its inception about a year ago, Leticia has coordinated a number of really impactful community programs and clinical programs that are helping medically underserved populations access care at Memorial Sloan Kettering and also access clinical trials. So, and this seminar tonight is just an example of the type of things that we're doing, because our mission here at Sloan Kettering and in the Office of Health Equity is to make sure that every single patient with cancer has the best possible outcome and can benefit from the amazing care and research that we do here at our center. So Leticia.
Thank you so much, Dr. Brown, for that great welcome. And I want to welcome everyone who's joining us on this Thursday evening. And before we get started, I just want to get a chance to get to know the audience. So when you have a chance, can you tell us a little bit about yourself? Are you a patient, or maybe you're a caregiver, or possibly a family member of a patient, or a friend or healthcare professional? Great. We have some healthcare professionals and patients in our audience. Welcome and thank you so much for joining us. It's great to be with you. We're also looking and want to get to know a little bit more. Where are you all from? Are you from any of the boroughs or maybe the outside boroughs, tri-state area, Connecticut? Great to see you all. Thank you so much for joining us. We have some of our participants are coming from Brooklyn or from Harlem, Manhattan. So thank you so much. Thank you so much for joining us. And without further ado, I'm going to go right in and introduce our wonderful panelists, starting with Dr. Park. Dr. Park is the Deputy Chief of Clinical Affairs of the Thoracic Surgery Service in Memorial Sloan Kettering and the Director of Lung Cancer Screening Program. He is a thoracic surgeon with extensive experience in minimally invasive video-assisted thoracic surgical approaches and is a pioneer in the robotic thoracic surgery, having been one of the first to develop the robotic lobectomy technique for the treatment of localized lung cancer. Thank you so much, Dr. Park, for joining us.
Thanks so much, Leticia. My pleasure to be here.
Good to see you. And next we have Dr. Pak, who is a medical oncologist and specializes in the care of patients with lung cancer. His research interest lies in developing new therapies for patients with non-small cell lung cancers. Dr. Pak is extremely engaged with the Office of Health Equity and focuses research on addressing lung cancer disparities in communities of color. Dr. Pak, thank you so much for joining us. Good to see you.
Hi, happy to be here. Shout out to Raul from Harlem also.
Nice to see you. And lastly, but certainly not least, Dr. Molina is a thoracic surgeon whose passion and expertise is dedicated to diagnosing and treating people with cancers of the chest, including lungs, esophagus, mediastinum, and all other parts of the chest cavity. Dr. Molina is the director of Memorial Sloan Kettering's esophageal program, and she is a strong patient advocate and aims to develop and study new technologies and image-guided approaches to make surgical resection more precise and effective. Dr. Molina, thank you so much for joining us tonight.
Thank you. This is a very important discussion, and I'm very happy to be here.
Thank you. So we're going to jump right in, and we're going to start with Dr. Park. Dr. Park, can you tell us a little bit about lung cancer screening? What is it and who should be screened?
Sure. So lung cancer screening is a test that is designed to look at people who are at high risk to develop lung cancer in order to potentially detect the cancer at a much earlier stage so that it could be treated effectively. There have been many studies done both here in the United States and across the world that have shown that if you use a very simple 5-minute screening test, that the vast majority of cancers that are detected are in fact stage 1 and can be effectively cured with either surgery or radiation and some other new therapies that are being developed, which is a huge development because as many of the participants in this wonderful webinar know, lung cancer is extremely hard to cure overall. It is the #1 killer of both men and women in the United States. And we know that screening can reduce the chances of death from lung cancer by over 6-fold in people who are screened versus those that are not screened.
Right. Thank you for that. And that brings us to a really important question. Who should be screened? Should everyone be screened?
Yeah, that's a great question. The large studies that were done were aimed at employing screening for people that were felt to be at high risk. So what was the definition of high risk? High risk really was related to the fact that we know that many lung cancers are associated with a history of use of tobacco in the past. It also generally is a disease of older people. And so based on that, the high risk population was defined as those that smoke the equivalent of a pack of cigarettes a day for at least 30 years, people between the ages of 55 and 80, and people who quit less than 15 years ago. Now, that was the original criteria. And as far as the tobacco exposure, so the calculation was a pack a day for at least 30 years. It could be 2 packs for 15 or 3 packs for 10 or half a pack for 60 years. So it's just a simple multiplication of packs per day times the years smoked. And one of the important things is that people should have quit less than 15 years ago. We know that that if you quit early, that your lung cancer risk after about 15 to 20 years can go down to that of almost somebody who's never smoked. So that's really important. The other really important thing that's happened recently is that the United States Preventative Task Force for cancer and other health conditions just recently completed some analyses that showed that actually the 30-pack year number and the age of 55 did not account for some populations that were at higher risk at a lower tobacco exposure and a lower age. That includes women, that includes minorities, so people of color. So they actually lowered the tobacco exposure to 1 pack for 20 years equivalent, and the age to 50. So, people that have had that amount of tobacco exposure starting at the age of 50, and again, quit less than 15 years, are recommended to have lung cancer screening. But people that fall outside that criteria, we don't want to screen everybody. There are many people that smoked a little bit in college and things like that, or maybe they got exposed to secondhand smoke, those things. The problem with screening everybody is that the CAT scans we use are really quite accurate and they pick up a lot of things. And we the incidence of cancer, even in the high risk population, if you, of all the people that are screened, actually, we wind up finding, of all the people that have positive findings, meaning nodules in their lung, still less than 5% actually are diagnosed with cancer. And so we don't want to screen everybody because there's a cost involved with that. There's anxiety about the scan. There are findings that often turn out not to be cancer that might provoke other workups and things like that. So we just want to be very careful to try to use this valuable test in people who are going to really benefit the most.
Right. So Dr. Park, you mentioned smoking and the history of smoking. Can you tell us a little bit and help us understand the stigma of lung cancer and how that's related to smoking and how we can help overcome that stigma?
Sure. I mean, it's a known fact that if you take everybody that is diagnosed ultimately with lung cancer, about 80% have some history of tobacco use. And so for a really long time, and it's also a disease of older people that may have smoked, again, for 30 years. And so I think the combination of those two things really creates this idea that, oh, well, people that get lung cancer brought it on themselves. They're to blame because they smoked, even though they knew smoking was bad. And so I think that many people feel stigmatized, and sometimes they even stigmatize themselves. They say, oh, well, I smoked. I don't, if I get lung cancer, it's my fault. And I don't, whatever happens to me, should happen to me. But I think that and so it's very difficult to fight through that kind of, stigma based on society, stigma based on your own perceptions of the role of tobacco and lung cancer. And in fact, in point of fact, there are many people who, 20% of lung cancer victims are literally never smokers, meaning less than 100 cigarettes in their lifetime. And yet they're very quick to point out, I have lung cancer, but I didn't smoke, because they don't want to be considered to be a smoker. There's just the stigma of being a smoker in general. And so I think all these things really come into play in terms of not being able to utilize screening as much as we should, and perhaps delays in seeking treatment when maybe there are symptoms involved, and a little bit of denial or not wanting to face the stigma of having smoked in the past and then possibly getting, lung cancer.
Right. We do have a question from the audience, and we mentioned the guidelines changes. Are the guidelines, do they include vaping, and or how has hookah smoking, increased hookah smoking, impacted the guideline changes?
Sure. I mean, currently, the guidelines don't take into account things like electronic cigarettes, vaping, hookah, but actually, it is quite well known that the compounds that are used to vaporize the nicotine have known carcinogens in them. So I think that simply because even though hookah's been around for a long time, things like electronic cigarettes, vaping has only been around for less than 20 years. And generally it takes about 20 years for the exposure to then result in a strong association with lung cancer. I think it's probably only a matter of time until we have that epidemiologic data. We just don't have it right now, enough strong evidence to incorporate that into the guidelines for lung cancer screening, unfortunately.
Got it, understood. Well, we have a question for our audience. Who do you think is the most impacted by lung cancer? You could please put this in the chat. Would you think women, women of color, men, or men of color? And as those answers start rolling in, Dr. Pak, can you just tell us a little bit about lung cancer disparities and what's the research behind it? Can you tell us a little bit more?
Sure. So there are a few different ways that we conceptualize lung cancer disparities. One of them is disparities as it relates to risks, and what's the risk if you're a Black man versus a white man to get versus an Asian man or woman of getting lung cancer, particularly as it relates to cigarette smoking. I'll get into a little bit of that data at the end of this. The other is disparities in representations of clinical trials, and that'll be a target. That'll be a topic for later on. We'll talk a lot about that. Another big one, of course, is disparities in access to care, which sort of is a common theme that permeates a lot of the disparities that we see in healthcare in general. And then the final one that is the sort of output of all of this are disparities in outcomes, particularly overall survival, chances of living with lung cancer, chances of beating lung cancer. There are differences. I think one of the most important ones to talk about, disparities to talk about in the context of lung cancer screening, is what Bernie had referenced when he talked about some of the changes that the United States Preventive Task Force had made earlier this year in terms of reducing the cigarette exposure required to be considered high risk and also lowering the age. So part of this stemmed from an analysis or recognition that a lot of these trials, actually all of these trials that studied the role of CT scan screening for patients who were smokers had a vast underrepresentation of African Americans in the population. So if you think about New York City, any major urban center, the breakdown is usually about 25% of the population is African American. In the National Lung Screening Trial, for example, the proportion of Black Americans represented in that study was 4%. And so you can imagine, well, 4% representation, there's not a lot of good conclusions you can make in that population. And yet we know from other data dating back decades now that the risk for African Americans, for reasons that we don't entirely understand, particularly when they don't smoke as much, when they're not like super heavy smokers, that risk of developing lung cancer is higher than in white Americans. Again, we don't really understand why that's the case, but it is a reproducible observation over time. And so the idea was, well, okay, so if all of these data, most of these data came from a largely white population, that's not necessarily applicable to an African-American community or other communities of color. So let's use existing data to sort of figure out how we might be able to model things where we can sort of accurately figure out what the right population to screen would be in communities of color. And so that was part of the rationale for lowering actually the age and the cigarette smoking exposure, was a recognition that these disparities exist and have existed for a long time, and a way to correct for that. So I think for me, again, without getting into a lot of other topics that we'll talk about later on, that's, I think, the most relevant disparity issue when it comes to screening that we've been able to correct over time, particularly this past year.
Right. So just to go back to our questions, thank you, Dr. Pak. We have a few answers here. Some men of color, but women catching up. Women mostly impacted, men of color. So thank you so much for giving us a little bit more insight. Very interesting about the lower smoking years, but higher outcomes. Can you talk to us a little bit more about the smoking rates in communities of color? You mentioned a little bit of that before, but can we dive a little bit more in?
Yeah, sure. There are a couple ways to take a look at this. One is, I think, on a general population level over time, and the other is if you just sort of zoom in on a particular community, what does that breakdown look like for smokers? And what we know historically, if you go back to the sort of 1960s, that the community that seemed to have, the demographic that seemed to have the highest rate of cigarette smoking was actually Black men. The rate of smoking in that population was 65% of all Black men were smoking in 1965. After that, it was white men, and then interestingly, white women, and then Black women. Those numbers over time, over the past 40 to 50 years, have gone down dramatically. So that's the first thing to note, is that there's been a great effort to try to get people not to smoke or to quit smoking, and it's been largely successful. So the incidence now, the frequency for cigarette smoking amongst Black men is down to about 20%. But that is the highest demographic in terms of the rate of cigarette smoking is in Black men. So white men and women are in between, and then Black women sort of are less than that. So But it is sort of Black men that where cigarette smoking is the most prevalent. And so, of course, is part of the reason why we're talking about screening in this population, because that's the major risk factor for developing lung cancer. The other way to take a look at this is if you just take a look at a particular cohort of people. In this case, there was a very large analysis done about a few years ago that was part of the reason why this change was made in screening guidelines. About 48,000 Americans in the South were analyzed, smokers, to see sort of what the outcomes were. And the breakdown there was that in that population, 66% of those smokers were African Americans, and then about sort of 30 to 40% were white Americans. So even in a community, you see that the rates of smoking are higher in the African American population, which again sort of gets at both the disparity issue, but also the risk profile, and why it is that it's so important to talk about screening in communities of color.
Absolutely. We do have a question in the audience and from the audience, and that has to do with, there's two questions regarding secondhand smoke. Can you give us a little bit more information about secondhand smoke, how it impacts and how that impacts screening, and also incidences?
Yeah, so at least for my sort of understanding and review of the literature, and Bernie may know more about this, it's the first issue is that secondhand smoke from an exposure standpoint is not very well captured. We don't have good tools to quantify exactly how much that is, right? One cigarette is a pretty good thing, you can quantify, but for secondhand smoke, there's all these variables that lead to differences in what that actually means. So that's the first hindrance, is that we don't have a good way of assessing what that exposure is. And so we don't really know, is the bottom line in terms of the data that we have. We do know from other analysis, I think the most recent one was a cohort of, again, over 40,000 women in the United Kingdom. This was published a couple of years ago, took a look at secondhand smoke as a risk factor, and it was a risk factor. The risk of developing lung cancer was about twofold higher than if you did not have secondhand smoke exposure. So the general sort of idea is that it's a risk factor. It's very difficult to quantify how much. And because of that, it's very difficult to make screening guidelines, because we actually need to sort of stratify patients by risk, and we need to quantitate that risk in order to do that.
Understood. Thank you so much. Dr. Molina, we would like to start talking a little bit about early detection. And can you tell us why early detection is the best, and what the stages of lung cancer might be, and how early detection might impact treatment?
Yes, so the lung cancer often does not give any symptoms in an early stage. So I want to stress about that, because often patients come in and say, I feel great, I don't have any problems. And, if I go to the hospital, some problems are going to be found. And that is unfortunately an attitude that is really not that helpful, because if you wait for symptoms to appear, often it is a little bit late in the course of treatment. There are, in fact, we talked about cancer, and in terms of staging, what does that mean? It means that when we talk about cancer, we want to define what is the extension of the disease, because every different stage is treated a little bit differently. And cancer usually is staged with 4 different stages, with stage 1 being the earliest and stage 4 being the most advanced. So when you have early stage disease like stage 1, it means that the cancer is just a very small nodule within the lung. And those small nodule within the lung almost never give any symptom at all. And so often we're lucky in finding them because patient maybe go for a CAT scan for other reasons, like a cardiac CAT scan, or maybe they have abdominal pain, they have another problems, and we find this nodule, and then we can follow in time. But screening is very, very helpful, because we can actually look at the lung of patients that are high risk. And if there are any abnormalities, we can follow them in time to better understand if those are potential cancer nodules or not. And so it is very important to find a cancer at the early stage, because the chances of being cured after treatment of a cancer that is early stage is much higher. So for example, we can diagnose a patient with stage 1 lung cancer. That patient has over 80, 85%, 90% chance, depending on the type of cancer, of being cured with treatment. So that's amazing, because really lung cancer is a deadly disease. And so if we do not find it early, then the chances for cure are much lower. Not only they're much lower, but the treatment is much more complicated and difficult. So for example, you go from a stage 1 chances of cure 85, 90% to for stage 1 to a 50% or even less with stage 2 or 3. So really it's very, very important to find early stage cancer, because often the treatment is much easier and the chances of curing the patients from their cancer is much higher.
Yeah. Thank you. Dr. Molina, you mentioned later stages might mean more complicated treatments. Can you talk us through a little bit more about the treatments, the treatment types? And often we hear a lot about minimally invasive procedures. What is that? Can you describe what that might look like?
Yes, definitely. So for early stage, I'm going to focus a little bit on early stage lung cancer. And for early stage lung cancer, the best treatment that we have to offer is resection. Then there are some alternative treatments that we can discuss, but really surgical resection means going in and cutting the cancer out is the best thing we could do for patients. Usually not only we cut the cancer out, but also we remove some of the lymph nodes, which are these glands where the cancer can drain to. And by doing that, we have a better really idea what the real stage is, because imaging like CAT scan or PET scans really help, but they are a little bit of a guessing tool, right? We don't know for sure if there is cancer cells in a tissue until we look at it under the microscope. So that's what resection does, right? So remove the cancer, remove the lymph nodes, and establish what the real stage is for the patient, and so determine what's the best care and treatment for the patient. So most patients with early stage cancer only undergo resection. And so in the old days, resection was done with a big incision in the chest, in between the ribs, and that's how the lung was accessed, and that's how the cancer was removed. But today we have a lot of different minimally invasive tools, which means that we are actually able to operate with small incisions in between the ribs. We put a camera in the chest, and we can put tools through also the ribs, either with just a camera alone. Sometimes we use the robot. There's a little bit more a fancier way to do minimally invasive approach. And sometimes we do that just through a very tiny small incision. It's called uniporal approach. So we're a different option for minimally invasive techniques. And the minimally invasive techniques means that we can work without making a very large incision in the patients, also kind of spreading the ribs that can cause pain. And if the patients can go through the operation, I'm not saying painless, because with surgery, there's always a little bit of pain associated with it, but the least amount of pain, the faster the recovery, the easier for patient to return to their daily activity of the things they like to do, but also means potential less risk for complications. Because if the patient is comfortable and can walk around and can cough and take deep breath, often we can avoid complications like pneumonia, respiratory problems that are associated actually and increase with the pain and the difficulties, to clear the lungs, to keep those lung clears. So those are all the techniques that really we like to use for early stage disease, but also sometimes with more advanced stage disease. And we do use minimally invasive technique also in combination with other treatments. So if the stage of disease is a little bit higher, so stage 2 or stage 3, we often treat patient first with chemotherapy or some of these new drugs that we have now available, like immunotherapy, for example. And then we do the surgery. And often we can still offer patients minimally invasive approach even after they receive these more complicated treatments.
Great. Thank you so much, Dr. Molina. You mentioned new approaches, new chemotherapy and immunotherapy. Dr. Pack, can you tell us a little bit about the differences between chemotherapy from maybe 30 years ago and what we have to offer today, and maybe what's new?
Sure. So we've made a lot of advances over the past 30 years in terms of different kinds of therapies, not just chemotherapies. The big advancement really in chemotherapy, I think, which we still use, is to improve how effective they are. But the biggest advance probably, and Memorial was a big part of this research, was try how to make it better tolerated because people still have concerns, and rightfully so, about how they're going to feel with chemotherapy. And a lot of this has been mitigated with different kinds of other kind of supportive care that we have. But the biggest sort of therapeutic pushes in lung cancer have been with targeted treatments. So these are treatments, largely pills that you take instead of intravenous treatments, that specifically target changes that happen only in someone's cancer cells. And at this point, there are some sort of 8 different things that we look for which we have paired standard of care oral treatments that are highly effective, more effective than if we were to give these patients chemotherapy. And they also have to be very well tolerated for the most part. And then the final big advancement over the past 5 years has been the development of immunotherapy. It's a class of medications that really helps the immune system to recognize someone's cancer, because cancers have figured out clever ways to hide themselves from the immune system. And the immune system's job, part of it, is to actually identify cancer cells and to kill them. And so there's a new class of medications across lots of different cancer specialties that help your immune system to fight cancer. And again, the great benefit of this is, by and large, these are better tolerated than chemotherapy. But in addition to that, it kind of makes sense. If your immune system's activated and it's doing what it's supposed to be doing, then it can work for a lot longer than some of these other therapies. And that's in fact what we've seen. And this is really borne out in terms of what we call a 5-year overall survival, especially for patients who have been previously deemed to have had incurable lung cancer, where that rate has gone back when I was trading even, it was sort of 5%, upwards now in certain patient populations to 30%, 35% in a relatively short period of time. So these are really great gains that we've made in terms of treatments that we have to offer.
Thank you. And gains that might be attributed to clinical trials. Can we talk a little bit about clinical trials and the importance of clinical trials in communities of color and participation?
Sure. I think there are a few reasons why clinical trials are important. For me, the number one reason actually gets at some of the things we've talked about when it comes to screening, which is, we're only going to know how to really sort of treat someone well if we actually see them and end up treating them. And so you can imagine in these big lung screening trials that instead of a 4% African Americans or representation of the population, we had 50%. So we had lots and lots more people to be able to do CT screening for. We may have uncovered even sooner what we've come to sort of realize after the fact, which is that there's a higher risk, we know for sure. And in this particular population, we should start screening earlier, for example, and with less smoking history exposure. So this is stuff we would only know if we actually ended up seeing patients, enrolled on these trials. So that's sort of the first thing, right? Is that we'll only know, if we're able to end up taking care of folks. The other reason is that clinical trials are a lot better, to be honest, than they were some 20, sort of 30 years ago. We are sort of much more certain, even before we start the study, that it's going to work in patients. And in fact, in these earlier stage trials, we've seen this borne out, where we sort of test something that we think is going to work and it ends up working, and then the FDA ends up approving that therapy even sooner than it would have in past times. And again, it's a good way not just to help your neighbor, but to help yourself in terms of getting access to cutting edge stuff that may very well make a big difference in terms of how you're going to do. And so that's the other really important reason to get folks involved. Of course, there are barriers to this, and if we have time, I'm happy to talk about these things. And that's, to me, sort of the most important thing for us to recognize as academic centers and as providers, are these barriers that prevent patients in communities of color to sort of accessing these trials.
Thank you. Thank you so much. So Dr. Molina, you talked a little bit about rates of survival with lung cancer by stages and emphasizing early detection. Is there more there in connecting that to lung cancer screening and how it might be impacted and improved by being screened?
Yes, definitely, because those patients that are screened are patients that have no symptoms at all. And so when they go for their CT scan, I don't know if we mentioned that the CT scan that we do for screening is a low dose CT scan, which means that we give less amount of radiation to the chest. And so it's a kind of a balance between risk and benefit, right? So we don't want to radiate too much. We don't want to do too many X-rays or CT scans because that radiation also gives some risk to cancer development. But at the same time, we want to see the lungs and we want to detect abnormalities within the lung. Now, sometimes these abnormalities, we are not sure what they are. And so it's not always clear that we see an abnormality in the lung and that's a cancer, or it's definitely a cancerous nodule. So sometimes we find things in the lung that we're not really sure, but that allow us to then put a patient in a surveillance kind of method. So we're gonna understand what are the risks according to the findings, right? And then we can tailor how often do we see that patient, how often do we do those CT scans. And often really is the behavior of these nodules that will tell us, right, if this nodule could be a cancerous nodule or not. So we follow the patient on with time, and over time we see that some of this nodule will grow, will become bigger in size, or sometimes they become denser. They start like a little thickening on the lung, but they're not real nodules. And then they become like more dense and more visible on CT scan. And that's alert us and alarm us because it suggests that something is happening within those nodules. So it's not that when we do a CT scan and we find an abnormality, we just jump right away to treat it or to biopsy or to find out exactly what that is. We just sometimes is indicated if it's pretty clear that it's a cancerous nodule to do more aggressive evaluation. But some other times we just put the patients in a program, and so that we can really carefully and timely look and follow these abnormalities. And only some of these abnormalities will then undergo a further and more aggressive evaluation if we are concerned that they might represent cancerous disease.
Great, thank you. Dr. Park, we have a great question from the audience. And the question is, are there genetic predispositions that exist in lung cancer? And for those who have history of lung cancer in their family, should they be screened earlier or at all?
Those are great questions. As far as genetic predispositions, we have actually a lot of clear information that lung cancer can run in families. Now, that is different than there being a lung cancer gene. As of right now, there is no, similar to, let's say, the breast cancer and ovarian cancer gene, the BRCA, so-called BRCA gene, there isn't an equivalent necessarily in lung cancer. We do know, however, that lung cancer can run in families, probably because of some susceptibilities, perhaps to certain exposures, whether it's smoke or environmental factors, things like that. So definitely there can be families where there are multiple family members that have lung cancer. But again, it's not an inherited condition, but probably inherited in terms of just susceptibility to some of the environmental factors that can lead to lung cancer. So unfortunately, that's hard to then incorporate into, recommendations for lung cancer screening. Again, there's, if you're a person that has very low smoke exposure, no smoke exposure, no other external exposures, it's right now, there's not a lot of data that would support getting a lung cancer screening test. However, what that means practically is that unfortunately, insurers, third-party payers won't pay for it. But certainly, it is an area of actually, some research and interest to see, whether we can expand or modify certain risk profiles. And there have been studies done in Canada and in Europe using some expanded criteria, which include a strong family history, other environmental exposures. And so I think we'll see in the field in the future coming up, some diversification of how we assess risk for that. Unfortunately, right now in 2021, it's currently not that aspect of the family history is not one that we can use to justify, getting a lung cancer screening test.
Got it. Thank you so much. It's very helpful. And actually, we're going to stay with you, Dr. Park. There was another question from the audience about fear of surgery and thinking that cancer could be spread through surgery. Can you talk a little bit about that, and if that's true, and how do we know?
Sure. No, that's actually a very common question that my patients ask me, and it's a very legitimate question. I think that, and the way I answer it for my own patients is I try to emphasize the fact that if you look at most solid cancers, kidney cancer, breast cancer, colon cancer, lung cancer, the number one curative treatment is surgery. And so that in and of itself should shed some light that, in fact, surgery is the main curative treatment for a lot of these solid organ cancers. I think the notion that that surgery itself or exposing the cancer to air can cause spread of the cancer, it is actually true that in experimental data that shows that sometimes as you're manipulating an organ that has a cancer, you can certainly shed some cancer cells into the circulation. Actually, that's been shown. But for the vast majority, those cancer cells don't implant anywhere. And so I think the other way that people often think that that surgery spreads cancer is that everyone remembers the horrible story when their family member goes to have surgery and the surgery starts and then they're found to have very widespread cancer, or they have the surgery. It's obvious it's often for a more aggressive advanced cancer. And then soon after the surgery, they develop, widely spread disease. It's probably a combination of just the nature of the cancer to begin with. And then there is some, obviously having surgery can knock you down a little bit, perhaps suppress your immune system a little bit, compromise your ability to fight off the cancer. And then that can certainly maybe promote microscopic disease that's already present to flourish. But overall, I try to reassure my patients that, again, for most cancers, and certainly for cancers that we would find in an early stage by screening, surgery is the number one treatment. And we do the vast majority of these surgeries now less invasively, as Dr. Molina said, and that preserves the immune competence. It's often done with less complications, and so people are able to recover better and get on to their any additional therapy if needed faster. And so I think that surgery remains the mainstay of curative treatment.
Right.
Can I jump in that as well a little bit? I think that I totally agree with Bernie about what he said, but I also wanted to say that sometimes the cancer might already be in the system of a person and we might not be able to tell, and at least not today, right? So we do the best we can with the tools that we have, but the tools that we have are limited. And so, we're doing a lot of research, like to, for example, identify tool in the blood system so that we can do maybe a blood test and we can tell if the cancer is more advanced than we anticipated or it looks like on scans and so forth. But sometimes we might do surgery because we think the patient is resectable, we think the disease is early stage, but indeed the disease is more advanced than we knew before we did the operation. And so sometimes the outcomes is not really related to the surgery itself, but it was there already before.
Yeah. Thank you for that insight. And Dr. Molina, we had a question about actually esophageal cancer. If you've never smoked, are there any tests for esophageal cancer similar to how there are lung cancer screening?
Unfortunately, I have to say, I'm very disappointed that there is no screening for esophageal cancer. And maybe that will come. You know, it took many, many years for lung cancer to actually have a screening tool. And so we have to work on that. All we know right now, the main risk factor, there are two types of esophageal cancer. And one is called squamous and one is called adenocarcinoma. And those two types have two different risk factors. And so all we know is what the risk factors are. So for the adenocarcinoma type, usually is the typical patient that had reflux disease for 10 or more years, usually male, usually a little overweight. Maybe they have had a hiatal hernia for a while. And that is the main risk factor that we know. So they're not really recommendation for screening, but today we're more sensitive to that kind of high risk individual. And so if there is severe GERD, gastroesophageal reflux disease, those patients should really undergo an endoscopy because that's the only way to detect the presence of cancer. The other type, which is the squamous type instead, we see more often like in smokers and drinkers. In fact, it's very popular cancer, like in other countries, and it's kind of decreased in occurrence here in the United States. But we see it rising more also in like after radiation to the chest, for example. So we have a fair amount of women that might develop even esophageal cancer because they had radiation to the chest, or maybe the breast cancer or other sites that are close to the esophagus. And so, you know, as with lung cancer, same with esophageal cancer, there's really not a lot of symptoms before the cancer is more advanced. And so often it's just found routinely because patients go on for having an endoscopy for other reasons. And so we really have a lot of work to do to really identify, you know, screening tools for these patients. Now, once patient develop Barrett's esophagus, that's a little bit of a condition that is associated with gastroesophageal reflux disease. Those patients actually can go on a surveillance program, but there is really no screening tool to detect Barrett's either.
Great, thank you. And Dr. Molina, you mentioned the types of cancer for esophageal. Dr. Pak, we have a question from the audience, and the question is, what is the difference between non-small cell versus small cell lung cancer? Can you give us some insight on that?
Sure. So the difference between non-small cell and small cell largely has to do with how aggressive these lung cancers are. And by aggressive, I mean how fast they grow and also how quickly they metastasize. And so for small cell lung cancer, which thankfully is the minority of lung cancers that we see, about 10 to 15% of cases in general will be small cell lung cancer. These tend to grow very fast. So one of the sort of metrics that we have is the doubling rate, or how quickly the cells are dividing. And for small cell lung cancers, most of the cells are dividing. They're actively dividing, which is not usually the case for non-small cell lung cancer. And you can imagine that if this is the case, then the outcomes are worse in this population. Patients are harder to cure. And for those patients who have incurable small cell lung cancer, the life expectancy for these patients are shorter. And Danielle is absolutely right. So the small cell lung cancer is a good example of a disease where what she was talking about in terms of the disease already having spread, even if it looks localized, that's absolutely the case for what's going on in small cell lung cancer, which is why surgery is not really the mainstay treatment for this, because in most cases, even if there's a single lung tumor, if you cut it out, it's already spread and it will appear in other places in a few months. And so it's just sort of the nature of that disease versus non-small cell lung cancer.
Thank you. We're going to continue with some questions from the audience. We have someone joining us from LA and would like to know a little bit more information on lung cancer in the Hispanic community, which is great timing since it's Hispanic Heritage Month. Can we share some insight, if any, research with the disparities within the Hispanic community? That's for anyone.
Yeah, so I can start with that. If we think about communities, different kinds of communities of color and representation in terms of the patients that we end up treating, I think the Hispanic Latinx community falls kind of in between the African American community and then sort of the sort of white community in terms of representation for those patients that we end up treating, but also representation in clinical trials. Part of the issue, I think, is in terms of sort of how we end up quantifying this, because the identity is not singular, particularly in this community, and so sometimes it's sort of hard to try to parse this information out. But I think the reality is, for me, for the Hispanic Latinx community as a community of color, it's still underrepresented, right? And access remains a major issue and a problem. I think we know comparatively less about this population in terms of the risk factors, for example, for smoking history, because of this representational issue, for example, and also comparatively less when it comes to representation in clinical trials and then as a result standard of care, because they also aren't really they don't make up a lot of the proportion of patients that we end up seeing. So, what I'd say is that it remains, I think, as a community of color, sort of a problematic issue that we aren't seeing these patients a lot, certainly relative to the population that makes up a particular city or a state, for example.
Great, thank you.
And I want to add a little bit to that, some studies that we have looked at in specific for lung and esophageal cancer in a different type of community, sometimes there is a cultural barrier to the fact that patients might not want to travel to a faraway location. I think that's a factor that often is not really taken into consideration. People feel comfortable to be close to home where their family member are and where the community is. And often, and this might be local hospital, community hospitals where maybe there is not access or opportunity to participate in clinical trials or to even participate in screening programs. And so I think that's something that is very important that maybe we are becoming more sensitive to. And I think even MSK, I think, has done some steps into bringing us and what we have to offer to the community with the regional sites. And I think that's a very important step for any providers to just go to their community where there is more need. Because often, there is this traveling, especially traveling to the city, it's really complicated. It's very difficult for some of these patients.
Yeah,
that is, I'm just going to riff off of that. That is super important to mention. And I'm glad that you mentioned that. It's sort of one of the things that tends to irk me about the way the healthcare system is set up. I mean, I'm going to channel Brian Stevenson, from the Equal Justice Initiative. It's about proximity, right? I mean, if we don't have proximity with communities, we're not going to know, and we're not going to be able to effectively treat these patients. And that's our colleagues at Longevity and the National Minority Quality Forum have generated sort of these heat maps for the United States that demonstrate where the different clinical trial research centers are and where communities that are sort of have a heavy burden of lung cancer are located. And there are these big deserts, basically, of clinical trials and academic centers in the United States, which is exactly what Danielle is talking about, where there's just no access, right? And so patients will go to their local community oncologist, and thank God that's the case. But they're not, this is not to toot Memorial's horn or Dana-Farber, but they're not an academic center that's going to have as much access to the kind of trial work that we're talking about, or even the expertise. And Lord knows we know for surgical disciplines in general that, the reason why Memorial is great for surgeons, because these, surgeons of ours, Carol, Daniela, and Bernie, they are experts. They do sort of huge quantities of these surgeries, and so are more skilled than the average surgeon is going to be. But again, it's proximity. If you don't have access to them, you're not going to see them, and your outcomes aren't going to be as good. And so, that is sort of the major thing I think that we need to work on as a society in terms of really making gains into marginalized communities, which happen to be communities of color, of course. And for me, again, I channel Brian Stevenson. I'll channel Luke 10, the parable of the Good Samaritan, right, where Jesus talking about the person who was on the side of the road, right? And the question is, who has been a good neighbor to that person, which means that it's not a passive thing. Just if you're sort of there but you're not helping someone, that's not the definition of as a good neighbor. It's sort of an active thing, and I think that's part of that switch that we need to make as institutions, where we need to be much more active and be good neighbors in our communities as a mark of and as a way to move forward.
Absolutely. Thank you so much. On that note, I'm going to open up for closing remarks. Dr. Park, Dr. Molina, any final messages to our communities who are out there? And thank you so much. We have a message in our chat, and bravo for mentioning the importance of proximity to our communities. It is extremely important, and a mission that we hold very close to us and something that we're constantly working towards. So thank you so much. But Dr. Park, Dr. Molina, if there's any last remarks that you want to add for our audience, by all means.
Yes, thanks. Yeah, I think it's been a wonderful discussion. I would say what I would highlight is that there have been a number of really key advances in both the detection and the treatment of lung cancer, not only early stage disease, but advanced disease. And so I would encourage all that, have legitimate risk of lung cancer, that or even those that have secondhand smoke exposure, lung cancer that runs in their family, to really, there are many ways now to undergo screening. It's very easy, fast, it's safe, and I think that we should get over the stigma of any past tobacco use, and really understand that there are so many innovations of how we can treat. We can preserve lung function. We do it minimally invasively. There are many personalized medical treatments, targeted therapies, immunotherapies. I mean, it's really a great time for advances in lung cancer treatment, but we can't treat unless we can identify. And I also think that the somewhat silver lining of our recent pandemic, and just talking about accessibility, at MSK, we have an alliance partnership where now with telemedicine and other telecommunication things, we can reach patients all over the country, all over the globe. We can provide support, and even in some cases, partnerships in clinical trials we have alliance partners stretching from Florida to Pennsylvania, where we are able to offer our MSK trials to patients in our partnership institutions. So I think it's really a great time for lung cancer treatment, as well as this collaborative approach that we can hopefully extend to more and more partners in the future. So I would encourage everybody, it's not a death sentence. They should pay attention and reach out to the resources they have, and we're happy to help.
Thank you.
Yeah, I totally agree with everything that has been said tonight, and I think this was a great discussion. I want to also say to patients out there that it is really our priority to really keep into considerations their wishes, their expectations. We're partners with patients. And so I think that the patient should not have fear of coming to see us and talk with us. It's not that we're going to say, oh, this is what needs to be done. There are lots of options, and there are options that might be better for you. They're different than another person. And so we're a team in this fight against lung cancer. And it is very, very important that we understand that the patient help us help them. And so understand what their needs are and what we can do to meet those needs is really, really important to us.
Absolutely. Thank you so much, Dr. Molina. And on that note, I want to thank you all for joining us, Dr. Pack, Dr. Park, Dr. Molina, and everyone in the audience. I am just going to pull up some quick information for you all who are interested in learning more about lung cancer screening. And or interested in an appointment with any of our wonderful physicians, the number is on the screen. It is 1-833-755-1650. And you're all welcome to call and ask questions. Our amazing thoracic team, both medical oncologists, surgeons, and radiation oncologists are open and willing to answer your questions. I think some of the key takeaway points from this evening is early detection is key. Lung cancer screening can save you, and we're welcoming to all questions. So thank you so, so much for joining us, and we hope you have a great Thursday evening. Have a good night.
Good night.
Good night.
Right.